going to start with a rather deep topic, and that is, how does one use the FHIR standard to support privacy consents? And what I'm going to be speaking to is an implementation guide from IHE. It is a implementation guide using the FHIR consent resource. I am, by the way, co-chair of both security work group within HL7 and in IHE, the IT infrastructure. So this kind of fits extremely in my wheelhouse, and I'm super excited that the idea is even useful enough for a webinar like this. So I'm pretty excited that it's coming a little bit into more interest. So I did go to the next slide. There we go. So I'm going to cover this. It's kind of a little bit longer than the time allotted, so I'm going to skip through a few of these slides. I'm happy to make the slides available. They're available through through the IHE as well. So the foundations, I'm not going to cover too much because it's going to be covered by some of the later presentations. Within this PCF, Privacy Consent on FHIR, is support for capturing consents, support for various kinds of consents, support for making authorization decisions and enforcing parts of those decisions. So generally speaking, what we looked at within IHE was, simple consents that might be used within an organization. These are not too common, needing to be in a standardized format, because if it's within your organization, you kind of, it can be an internal affair, so to speak. But we then get into this question of, well, is there a centralized consent, authority? Is there some place that can be available within a health information exchange for consents that cover the whole health information exchange? Consent authorizing just data requests, basic consent, things like implied consent versus explicit consent. Some people call those opt-in, opt-out, but I do not, because those terms opt-in and opt-out are very ambiguous. And then what I really wanted to hit upon with this implementation guide was these intermediate consents. So there's some consents that are quite easy to do with OAuth and residual policies. And then we get into advanced consent, which really uses the data tagging that you're going to see some discussions later on. So I'll probably not cover that too much, except to explain that they're in scope here, and watch the other presentations for how that happens. I'm not going to go into policy, but that's just, how IHE lays things out. So first thing up is we have an appendix that talks to writing of privacy policies. And this is not really interoperability. This is fundamental blocking and tackling, so to speak. Who gets to do what? Who gets to do what when there are consents on file? And what happens when you have conflicting consents? These are some use cases that the policy world has to work through. And if you don't have that, it doesn't do you much good to be talking about consent, so to speak. These are usually based on RBAC, or more likely ABAC, attribute-based access control. Do you need to concern yourself with break glass? Who has the authority to break glass? What happens when they break glass? Is there some follow-up to make sure that that breaking of the glass was appropriate and handled appropriately? And then audit logging is something that I'm a big fan of. If you can't track what's actually happening, you don't know if too many people are using break glass, just simply because it seems to get in their way. This I'm not going to dig into, but security labeling services are important. I think Mohammed will get into this, but the idea is, how do you find within your whole data set what are some stigmatizing pieces of information, and how do you tag them so that they can be used? So here I am at the beginning of the privacy consent on FHIR. That was a lot of the background material that is necessary to get us going. And first up, we start with use cases with, how does one record that a consent ceremony has happened? The patient was given a set of choices, they selected from those choices, and that gets captured in a privacy consent resource. Supporting of the maintaining over time. A lot of times consents need to be updated because new policies or new workflows, or now all of a sudden the organization has machine learning that they want to train. So privacy policies change. So how do you maintain that over time? And what effect does that have on access control? And then part two really gets into enforcing the privacy consents that are recorded. What we did was we integrated the enforcement into an OAuth flow. So we're kind of used to Smart on FHIR as an OAuth flow, and we integrate this in. It's no longer just Smart on FHIR, it's Smart on FHIR Plus, those kinds of things. So this is the set of actors and transactions that IHE privacy consent on FHIR comes up with. And I'll get into each of these in the coming spaces, but off on the left, you see the recording of consent, and then the dominant, three things in the right middle is recognition of an OAuth triplet. So you have your client. It wants to access some kind of resource, and it needs to go through some authorization server to get access to that. So within PCF, what are these transactions? Well, the capturing of consent, we did kind of take the easy way out, and we said all of the hard stuff is going to be handled inside the consent recorder. It's going to have to figure out how to interact with the patient. It's going to have to figure out how to present the alternatives. It's going to have to figure out, maybe does it utilize privacy preferences that the patient may bring to the table. All of that complexity is inside of the consent recorder, and it's also responsible for making sure that it doesn't allow something to be recorded that can't be enforced in this particular organization. So yeah, we cheated there. There are some efforts to go ahead and try to address that. I think FAST has a project that's looking to try to address that. But that's a whole lot of user experience, application behaviors. And from an interoperability perspective, we just wanted to say, well, okay, you record your consent resource. It either meets one of these profiles or it doesn't. And within this organization, it meets the requirements that can be enforced, those kinds of things. So it's just standard create, read, update, delete, and search. So it's nothing really shocking here, except we do have a number of profiles on the consent resource, which is up next. And I'm not going to be able to get into them in the time allotted, but essentially, we have them broken down into these 4 areas. And the first one really isn't profile on consent. The first one is just recognizing that there are some basic policies that you build upon. So we defined a policy which is could be further refined within an organization for the normal treatment, payment, and operation. Another one that says normal activities at this particular. Another one that says nope, I'm not allowing my data, but I will allow break glass. And another one, which we expect not to be picked too often, which is deny all. I don't even want break glass to work. Let me die if the doctor thinks that he can bring me back to life. We have to start with those basic groups, because until what is normal, you don't really know where to go with this particular patient. So then the first of the 3 groups, explicit basic consent. This is really just, a core consent. It has a time frame maybe. So this consent is only good for 2 years. It has, maybe a listing of who is authorized to see the data, or specifically who is not. It indicates who gave the consent, because consent typically is thought of as being given by the patient, but in many cases, there is a reason for some kind of a delegate who gives the consent, because the patient might not be of age, might be too old, those kinds of things. And then what are the purposes of use that are authorized? There's really not much that gets specialized on a patient-by-patient basis, but you have the ability within there to indicate when the consent ceremony happened, when does it need to happen again, who was there, those kinds of things. We then have this explicit intermediate group. This is where we start to bring in some of the simple vectors. And I'm going to say simple vectors because it's things like data that was authorized in 2014, I do not want you to show, or this particular, I do not want you to show. And then, obviously purpose of use is always a good vector to have available to you. So these are some pretty simple. They don't require security labeling services because they're leveraging the fact that all data within FHIR has these concepts of when was it authored, what is its identity, who authored it, and does it have a relationship to an episode or an encounter. And then we get into the advanced, which leverages security labeling services that have classified the information into alcohol abuse or substance abuse or sexual activities or what have you. There's some concepts. And you could have a consent that says, hey, I'm okay with the alcohol abuse, but there is this stigmatizing concept I don't want shared. So that's what this group has the ability. And then clearly being able to combine things and say, hey, within this time frame, but also this particular security label. So you can have combinations. So we now have to do access control. And this is the diagram on the right-hand side that I showed you before. Predominantly, it is made up of the classic OAuth triplet, except that it has these additional consent authorization server, which is utilizing the consents. They're coming in from the left-hand side there to help with making the access control decision. And it can outright say, no, this particular scope being requested is just an outright no. Or it can say, yep, no problem, nothing in the way. Or the worst case scenario is we need to trim the scopes a little bit, but we also have to give some residual rules to the grouped where there's a consent enforcement point. And this is, we embed these rules in the OAuth token, so they flow over to there under the normal means. And yes, there has to be an agent over there that understands how to read these things and is going to enforce those rules. And again, don't expect it to enforce something that it's not designed to enforce. But the idea is that you can pass some of these particular things. And oftentimes it's things like, hey, if this, data object ever shows up in a search result, remove it. Or if anything with this time frame shows up in the report, remove it. So it's usually those kinds of examples of just remove it. This is a diagram. It's in the PCF. I don't think it's going to do us any good to try to drill into it. But the idea is showing what I've been kind of verbally going through, and it's kind of showing how these various actors dance, how the consent, having been profiled, interacts with the extensions in the OAuth, those kinds of things. And then this is another eye chart, but I think it's it's the place where I'll spend just a minute that I have. I think this is my last slide anyways. But you can see on the left-hand side. So this is, for example, I am okay to allow normal treatment, payment, and operations, but not any data that's been authored by Dr. Bob. So what you have is that we're saying, hey, this is based upon some fundamental base policy. It starts with a permit of treatment, payment, and operations, and then it has a sub provision in here that says deny data which is authored by commissioner in this case. So it's actually, not that hard to understand, and that's kind of why I put it on the slide, because these do get a little bit more complex. And then when a data request happens, you can see that the deny authored by Dr. Bob is not something that you can put into a classic OAuth scope. So what we do is we have an extension, and IGE, IUA has their extensions. That's where we stuff the purpose of use stuff, because it's part of IUA. We didn't have to invent that. But here we have this additional extension, IG PCF, and it is indicating that the patient ID is this patient. Where did this policy come from? Well, this is the consent. That's this thing over here. So it's using a FHIR ID of that consent. And then there's this residual section, which says deny data authored by Dr. Bob. So this is all that needs to be unusually handled at the FHIR server side, in that additional resource server side agent has to be looking at all the data that comes through for anything that was authored by this particular reference. I would normally go into a hands-on, but we don't really have the time frame. But by all means, go on into the PCF, take a look around. There's a lot of examples in there, both for consents and the way in which the OAuth would look.
Presentation, and I think we can spend like a few minutes.
Sure.
The questions. Yeah, so we will reduce our discussion section. So I don't know, Steve, maybe you can like tell your question by voice.
Okay. Which Steve are you talking to?
Steve Lane.
Oh, okay. Sure. Yeah. I had basically, I did ask the last question, just are we going to be able to get the slides and recordings posted to the website so that they can be easily accessed? That was one question. The other question was that there is a lot of wonderful information here. And I thank you again, John. Every time I listen to you, I understand it that much better. But I'm curious whether there is a kind of maturity model or proposed development pathway that implementers could follow, especially as they're trying to deal with federal and state privacy requirements that would allow us to sort of do the minimum necessary using the appropriate tools initially, and then build this out over time to provide greater functionality.
Yeah, so I guess my initial reaction is it's going to very much depend on your technology stack, right? But that's the whole purpose of having basic, intermediate, and advanced, was to kind of indicate that basic is really very powerful, but doesn't put much additional burden on the infrastructure. It kind of turns into a go, no-go kind of a situation, but at least it gives this ability to have consents and have consents time out, have consents specific to purposes of use, which does enable things like being able to have a consent purely for a research project. Intermediate, I think, is the next level, and advanced is certainly much harder, but maybe the talks after me will prove that's even easy.
Thank you. And here maybe, Josh, you can express your doubts about that intermediate can be expressed without security labels.
Yeah, I mean, this might even apply to the basic area, but just to pick on one example, something like an episode of care, it might be very expressive to let an individual say, I'm interested in sharing my health data, but none of these problems, related to my particular episode of, treatment around a substance abuse case. That makes a lot of sense to let individuals say, but I don't think that data are consistently associated with an episode of care like this. So even though you might be able to write it down in FHIR, I don't know that you could really deploy a system like that in a real clinical environment.
Yeah, and I think this is very healthy skepticism, and I'm all for it. I just worry that this healthy skepticism is being used to prevent any improvement. So I think if we were to go forward, we would find some things slip through the crack, no question. But I think we can benefit by moving into the space where we have intermediate consents, and I don't think there's any absolutes.
Yeah, no, that's fair. We have a very low bar today in terms of functionality that we could improve on.
Okay, and maybe Jason, can you tell a little bit more about FAST Consent Working Group? So just announce it.
Yeah, so it's kind of in there, right? The second and fourth Friday of the month for meeting as the consent. I'm not one of the chairs, but just trying to participate there. And yeah, we're just trying to put like what different types of consent are in scope and out of scope. Does it come from patient to provider to payer, all those different use cases. And as mentioned, there's a lot of good discussion this last week, and very interested on taking that, to the next level.
And what
working with John's stuff on that as well.
Are you going to with all this?
Yeah, that's the goal. I mean, I think we're on meeting 2 right now in the process, so it's very early, so we don't have like a timeline on what that's going to look like. I think we're just trying to figure out scope and like what work we want to try to accomplish, and then we can have a better idea of like what the outcome is. Is it a full when does that IG come out? All that.
Yeah, that's amazing. So, and John, do you participate in this working group?
When I can, yeah. Unfortunately, I think the time slot conflicts for me right now, but I participate as much as I can.
Okay, so I think let's stop for now. So everybody welcome to working group. Everybody welcome to put some questions for the later discussion, and we move forward.